I'm so honored to be here and to see all of you here. I'm really thrilled that SAEM saw the wisdom of putting together this workshop and then, of course, having the keynotes tomorrow. The talk that I'm going to give is really a little bit of a overview of the epidemiology of firearm injury and a bit of my perspective on it. I know that I've worked with many of you in this room before, and then there are some new faces who I'm excited to get to know. I'm going to start actually by sharing, going off of Lauren's work, the story, two stories about why this matters for me. One is a clinical story. It's one among hundreds, right, that most of us have. And then the other one is a more kind of academic story. And the reason why I'm going to share them is that I think it's important for all of us to come at this knowing that this is truly a safe space. One of the things that I pride most about my work and the folks that I'm sitting up here with today is that we perceive this issue as one that we need to fix collaboratively. And I think that one of the things that has really divided us and prevented us from making progress is our turning this into a purely political issue. Is policy part of solutions to public health problems? Absolutely. But is it sufficient? Rarely. And your question of the man in the back, I apologize, I didn't catch your name, about Australia and why it's so different. Pat and I were sitting up there and we're like, man, it's all three, right? It's all of these different things that are making us see this epidemic. So my goal in kind of my first part of the presentation is going to be to give a little overview of the epidemic and then to lead into kind of some more discussions of solutions. So I'll start with my stories. So the first story is one that really changed my sense of gun violence. So I've been doing violence prevention work for a very, very long time, early on with domestic violence and sexual violence. I did a fellowship in injury prevention and talked about violence kind of in terms of either it was violence against women or it was community violence. And in one of my early shifts as an attending, I was working in our trauma rooms on like a Saturday, July night. So all of us that work in level 1 trauma centers in the US know that that means that it's like the quote unquote knife and gun club, right? So you're like prepared. And I've got a bunch of PGY2s who are super excited because it's their first time in the trauma rooms and they're like going to get to do procedures. And we get a call over from EMS that there's a trauma code blue coming in, GSW. And so we kind of all prep and we think that we know what's coming in. And the patient comes in the door and it was not at all what we had expected or prepped for. It was a young man who had shot himself in the head. And as the story turned out, he'd shot himself with his dad's service weapon. He'd had an emotional, a big kind of personal issue that day, knew where the key to his dad's safe was, and got the service weapon and shot himself. And I live in Rhode Island. As Lauren had mentioned, I'm at Brown, and we're a very small community. We're only 1 million people in the whole state. So everybody in pre-hospital and everybody in law enforcement knows each other. And so kind of the rooms, the halls of the ER got lined with folks paying respects to this dad whose son, word spreads quickly, the son who died. And there were so many things about the scene that struck me. One was that it was the only time I've ever seen someone who shot themselves. Still, 15 years later, only time I've seen someone come to my ER who shot themselves. And I know Emmy's going to talk a lot more about this, but there's a lot of reasons for that. And that episode made me start thinking about that. The second thing was the change in the tenor of the room and the ways in which we just accept structural violence in communities and all of the implications of racism and social determinants of health. And the fact that this kid, everybody came and lined the halls of my ER, but all the other kids that come in every day getting shot, nobody comes in and lines the halls. Right? People go, ooh, I got a thoracotomy, right? And it just highlighted to me the difference in the way in which we have to talk about the social issues in addition to talking about kind of the violence itself. And then the third thing that it highlighted for me was the degree to which guns are different. If that kid had tried to commit suicide in any other way, he would have survived, most likely. I can count on one hand the number of people I've seen in my 15 years of practice who've actually died, right? And guns are different. They're different when it's a suicide attempt. They're different when it's community violence. And they're different when it is unintentional injury. So that's my first story. My second story is a more academic story. So after Sandy Hook, I had been told for years, so like I said, I've done injury prevention. After Sandy Hook, I said, and I had been told for years that I couldn't talk about gun violence, that I could talk about violence prevention, I could talk about suicide prevention, but I couldn't research guns. And after Sandy Hook, I said, this is crazy. Who says I can't research guns, right? Who says that I can't talk about this, that it's going to kill my career? And so started working with ASAP and then SAEM and other organizations, including the people up here, to try to change that. And as part of that work, I met this guy, Chris Barsati, who I'll talk about a little more later in the talk, who's a community ED doc in Vermont. Now, Vermont is a small state. It's about 600,000 people, 600 to 900, depending on how you count them, 1,000 people. It has the highest rate of mass shootings in the country when you count mass shootings as 4 or more deaths, because they have a really high concentration of guns, a really high concentration of substance use, and it's really rural. There's not a lot of access to mental health. There's not a lot of police, and it's a very libertarian state. And Chris came up to me because he'd had a bunch of stories after I started talking about gun violence, and he came up to me saying, you know, why don't we have stuff that we can do in the ER? He's like, I take care of people all the time that get brought into me for assessments of violence, and I don't have any guidelines or protocols to follow. And I looked at him and I said, well, it's because we don't have research. And he said, well, what are you doing about that? And I said, oh, I'm working with an ASAP. He's like, no, but what are you really doing about that? And it kind of lit this thing in me, which has ended up with this conference and many other things that many of us are doing. And again, I'll talk a little more about that. But it was this call to action. It was this sense that it's on each of us, that we may see these clinical experiences, we may have personal experiences, but at the end of the day, it's up to each of us to make a difference in how we approach this. And I think that over the course of the next 3 or 4 hours, we together are going to hopefully come up with some ways that each of us can walk out of here and make a true difference tomorrow. Some of those will be small, some will be larger, some are quick, some take a long time. But with this incredible panel, I think that we're going to really come up with some great solutions. One other thing I should mention about Chris is that he is a firearm owner. He has multiple firearms. His kids go to shooting class. And another thing I learned from him was the value of collaboration. And we'll talk about that too. So, all right, so without further ado, I am going to acknowledge Marian Betz and Garen Wintemute, with whom I've given portions of kind of the slides that I'm going to show next. So again, my job here is to really talk about the numbers. So to start us off, kind of all being centered in what the truth is about firearm injury in the United States. So I'm going to start by acknowledging that firearm ownership rates vary tremendously by state. You're at PNS. I went there for med school in the early 2000s when there was a fair amount of firearm injury still coming through the doors. But you know, New York State, where I live, Rhode Island, has some of the lowest firearm ownership rates in the country. You go to Georgia, it gets a little higher. You go out to where Emmy is, we're somewhere around 30 to 40%. And then, of course, Alaska and the Rocky Mountain area is over 40% of folks report owning a firearm. I will say those stats are not super reliable because we, of course, don't have any federal tracking of firearm ownership. But I put this up because I want to acknowledge that what we talk about with firearm injury and how we approach it is going to be a little different depending on where we live. The patterns of injury and death also differ across the country. So in this map, lighter blue colors are lower rates of death, darker blue colors are higher rates of death. Alaska consistently comes up at or near the top, Alaska, Missouri, Louisiana. Any ideas why Alaska is so high? Why does it have the highest rate of gun death in the country? Suicide, yeah. Which brings up an important point, that suicide is a big part of this, right? So on average across the country, the rate is around 10 to 12 per 100,000. But in my state, it's about 4 per 100,000. And in some states, it's as high as 25 per 100,000. So there's huge variation. One of the other interesting things about this map is that you'll see that there's not a one-to-one correlation between the last map, which shows firearm ownership, and this map, which shows firearm death. And I think that's an important point because it gets at what I know Jeremy's going to talk about, which is that so there are lots of great studies out showing that having a firearm in the home increases your risk of homicide, suicide, domestic violence, death. But firearm ownership is not a monolith. And I think that one of the most interesting things that we can look at are what are the markers of safe gun ownership, and at what point does someone become too risky to own a gun? And I think that this map really highlights those differences in safety. So in 2016, actually I apologize, I thought I had given you updated slides, I'm sorry. So actually in 2017, there were 39,000 deaths and 130,000 injuries. So looking at kind of drilling down into the epi of kind of who dies from firearm injury. This is the pattern of men who die. So along the bottom is age group in 5-year increments. And going along the y-axis is absolute numbers in thousands. So you can see that there's a big spike in firearm deaths in kind of the young adult years. And then there's a plateau through middle age that kind of goes down as you get older and generally die of other causes. Women die kind of at a more consistent rate starting in those late teen, early adult years right through. 86% of firearm deaths in this country are male. I'll say that's similar to most other types of injuries in this country, of course, right? For women, the vast majority of firearm deaths are domestic violence. The most recent statistics say that 76 women are killed per month in a domestic violence homicide with a gun. I'm not going to talk a lot more about the women for now, but I think it's an important thing to come back to at some point during our discussion. So now if we go down into kind of the men who make up almost all the gun deaths in the country and break it out by race and ethnicity. Again, age groups along the bottom, absolute numbers going along the y-axis. So this is the pattern of firearm death among non-Hispanic whites. You can see that, again, there's a little bump in that young adult year. Then there's another big spike in that kind of like 40s to 50s, right, which surprises a lot of folks when I show this graph. Here's non-Hispanic blacks and Hispanic, and you see that for minority men, there is a huge spike in deaths in those young adult years and then virtually no deaths later. And to me, this graph highlights that there are in some ways two epidemics in our country. One is firearm injury and death among young minority men who live in the inner city, for the most part. Young minority men are disproportionately affected by firearm injury, and again, it gets into those social determinants of health, structural inequities that I mentioned. And then there's the non-Hispanic whites, who actually make up 62% of gun deaths in this country and are almost all suicides. With kind of some exceptions in those young adult years. And looking at the epidemiology in this way is critical because, again, I think it takes us out of the politics and allows us to talk about the true facts of what's going on. When I talk about firearm injury prevention with my uncle who's a Secret Service agent or my uncle who's National Guard, they're like, that's not something that touches me, right? And so we can talk about the ways in which it does touch them. And I think that one of the best things that we can do as we go forward in trying to change this epidemic is to highlight the ways in which this touches all of us. Why are people dying? That previous slide kind of gave us a clue. But in 2017, again, there were about 40,000 deaths. Only about 1% of those were accidental, or as I prefer to say in injury prevention, unintentional, right? These are things like toddlers finding a gun in their parents' nightstand, accidentally shooting themselves or a family member. These are totally preventable, but is a very small part of the epidemic. Only about, and we don't have great stats, but somewhere around 0.3 to 1% of deaths nationally are mass shootings. It really depends on how you define mass shootings. There's one definition by the FBI. There's another kind of, does it go into the, was it a mass shooting when 4 people got shot in Philly last weekend, right? You could say it was, but it doesn't count that way. But these are the things that make the headlines, but they really are the total minority of the deaths in this country. About 40% of deaths are homicide and legal intervention. I group these together because it's very difficult with the data that we currently have to separate them. But again, when we talk about structural inequity and social determinants of health, I think talking about them both together and separately is really important. And so one of the things that I'd love to see in research, and there's been some nice stuff done out of BU, is to think deeply about patterns of police violence, as well as homicide and how we prevent both of those. And then 2/3 of gun deaths nationally are suicides. And this is true not just in 2017 or in 2016, but since Emmy and I first started giving this talk together, a version of this talk together in like 2012, it is always 2/3 of gun deaths in this country are suicide. And this is critical because, as Emmy will talk about more, this is just so very preventable. I am going to give a nod to the fact that in injury prevention, we classically talk about an injury pyramid, right? So we talk about there's one death at the top, right? So for every death, you have maybe a dozen people who are admitted to the hospital. You have hundreds who come to the hospital and are sent home, and then thousands more who never even come to the doors of the hospital. With gun violence, it's different. It's almost a straight line. It's like a 2 to 1%. So for every 2 people who are injured, 1 dies, and almost all of them come to the hospital. But I do think it's important for us to acknowledge those who are injured and survive. And this graph is something that was made by a friend of mine after Parkland last year, showing kids affected by school shootings. You can see the bright greens are school shootings, and they circled Parkland. The dark blues are daily injuries, the dark reds are daily deaths, and the light colors are cumulative. So although we talk about these mass shootings, and although we talk about deaths, the reality is that every day across the country, kids are being affected by school shootings. And it's usually stuff like the shooting that happened in my city last month, where a kid was shot as he was walking out of his high school and died, right? And another kid was caught in the crossfire. Those are the school shootings that happen here and that are destroying our kids, right? the big ones are creating fear, but the other ones are creating long-lasting PTSD, substance abuse, et cetera. And I know Pat's going to talk more about the pediatric side of things, but I'll mention here, as I know he will, it's worth repeating, that firearm injury is the second leading cause of death for kids in our country. And this is a big part of the reason why. So with that kind of basics in the epi, I'm going to say that we could talk more about some of the details and risk factors, but the reality is that that level of granularity is about as good as we have because of the lack of research over the last 2 decades. We really lack the kind of detailed predictors, for the most part, of who's at risk for firearm injury and how to prevent it that we would have for other types of injuries. If I were up here giving a talk about the epidemiology of falls, you'd better believe I'd have a lot more epi slides. So I'm going to end that part with just that caveat. All right, so let me move into a framework for action that's going to give us kind of a sense of what we're going to talk through over the next few hours. So in injury prevention, we talk about the public health approach, right? We talk about there being something called the 3 or 4 E's that we use over and over to try to change patterns of injuries. And these are education, so things like teaching people about safe storage, or teaching people about the importance of using a gun safe, or teaching people about the right way to handle a firearm. Enforcement and enactment. These are things like having laws. These are policies and then enforcing them. So one of the things in some of the shootings that you've probably read about, so like there was the Sunderland Springs shooting last winter in Texas. The man who committed that mass shooting should not have been able to buy a gun. He was absolutely forbidden from buying a gun by any background check laws, including the current federal laws. And so part of injury prevention is enforcement. And then there's engineering. This is things like making it so that it's tougher to unintentionally shoot yourself, or that someone else can't pick up your gun and shoot it. So there are kind of 3 classic types of interventions that are applied in injury prevention. When we create those interventions through kind of a 4-step process. First, we say, what's the scope of the problem, the epi that I already presented. Then we identify risk and protective factors. We talk about what are the causes, who's at risk. Then we develop those 3 types of interventions. We talk about what can we do to educate, what sort of engineering, what sort of policies, where do we need to enforce. And then once we figure out what works, then we go and put it in place. We scale it up, we disseminate it, and then we make sure that it works. This process of using the public health approach and developing these 3 E's, these 3 types of interventions, works. I'm going to present a little evidence. So here's our evidence about car crashes. So car crash deaths in the 1950s and 60s was around 20 to 25 per 100,000. This was the era of the big Cadillacs, right? The big steering wheels. People would go through, be in a car crash, not be seat belted, go hit the windshield. The windshield would break into 1,000 shards. People would get impaled. They'd get ejected from the car. There were no drunk driving laws. There were no car seats, right? Then folks, including a bunch of emergency physicians, said this is not sustainable and did research and applied that public health model, developed education, policy solutions and enforcement, and engineering solutions, right? They created drunk driving laws, graduated driver's licensing, seat belts, airbags, collapsible fronts of the cars. We created ATLS. We have trauma systems, right? And through those efforts, we decreased car crash deaths from around 25 per 100,000 to currently around 10 per 100,000. Applying these strategies works. Similarly, with a very different example, applying these strategies worked for HIV/AIDS. So 1980s, when I was a kid, there was no HIV, right? Like we didn't know, then there was like gay-related immune deficiency, and it was like HTLV, and we identified that there was this pattern of deaths that were happening. The number of deaths shot up, we identified AIDS, and then we put a ton of money and a ton of resources into developing science to inform prevention. It started with private foundations and then was quickly followed by federal government money. We identified the AIDS virus. We developed antiretrovirals. We educated people about safe sex, right? We didn't tell people not to have sex, but we developed solutions that help protect people and to reduce the number of HIV/AIDS infections and make it, for most people, a chronic survivable illness. Again, do we have more to do? Absolutely. But it shows that this public health approach works, right? And now compare it to the death rates from firearms. So the death rate from firearms, this slide is a little bit outdated, but is currently around 12 per 100,000, higher than it was in the 1950s, a little lower than it was in the 1980s and 90s at the height of the drug epidemic that we experienced in New York City at that time, but has been gradually rising since 2010. So study after study shows that our rates of gun deaths are going up year after year since 2010, since kind of that nadir. And the reason why we haven't decreased it, I will submit, is actually really simple. It's because we really have not applied this public health approach. When we use it, time and time again, it works. So over the next few hours, we'll talk about the ways that we're already involved in preventing firearm injury, certainly with patient care. Some of you mentioned that you want to do a better job talking to your psychiatric patients. We certainly want to do a better job with our resuscitations. We're already involved with hospital and clinic safety. I'm sure Eric will talk about some of his work in disaster preparedness and kind of the ways that we try to keep ourselves and our nurses safe. And we're already involved in legal questions. You know, for most of us, it's a mandatory reporting if someone comes in with a GSW. But I also think that we can develop, as I said at the beginning, a way to be part of the solution. And I'm going to talk just a little bit about one part of that solution. Lauren asked me to add this in. So I mentioned at the beginning kind of the guy, Chris Barsotti, that came up and really changed my approach to firearm injury, where I'd really taken this kind of, I was going to work from an organizational standpoint and from a peer research standpoint. Chris and I worked together for years within ASAP and within some other organizations, and then finally kind of looked at each other and said, this is crazy. No one else is doing anything. It's time to just kind of do this ourselves. And so created this organization, AFIRM, the American Foundation for Firearm Injury Research, Reduction in Medicine, which is dedicated to ending the epidemic of gun violence by applying the public health approach. We're raising money across the country, developing educational products and funding research, including a few grants that are about to be announced from a joint EMF-AFIRM grant-making program with the goal of really kind of changing this conversation. And we see our role as kind of spurring some innovative research, but also bringing people together to really, again, kind of change this conversation. So events like this are an opportunity for us to help to spread the message that this is something that can be solved and that we can have hope. Over the past 2 years, we've created a coalition of over 20 medical organizations, including nurses, psychologists, medical students, trauma surgeons, et cetera. And we helped lead the This Is Our Lane movement back in November, which I'm sure many of you were aware of. The NRA tweeted after a report from the American College of Physicians that someone should tell self-important anti-gun doctors to stay in their lane. Half the articles in Annals of Internal Medicine are pushing for gun control. Most upsetting, however, the medical community seems to have consulted no one but themselves. And of course, this understandably got a lot of us really annoyed because if we're not the ones who are treating these patients, who is, right? We're the ones that see them every day coming through our doors. And P.S., most of the articles in Annals of Internal Medicine aren't about gun control at all. They're about ways to approach patient-physician conversations. They're about the effect of policy and whether it actually works or not. They're about ways to create change that's collaborative and forward-thinking. So in the wake of this tweet, right, we saw hundreds of thousands of tweets from physicians, nurses, social workers, physical therapists across the country who said this is very much our lane and really took what had been already growing within the medical community and helped to cement the forward movement. We were very proud to help lead that. And then, of course, the last thing that I'm going to close with here is an acknowledgement. You know, I said at the beginning that this is a safe space, but I also want to acknowledge that a lot of us have personal stories. And I do want to take a minute to recognize Tamara O'Neill, who was a fellow emergency physician at University of Illinois, Chicago, who was murdered as she was walking out of a shift by her ex-fiance, shot at close range. Her ex-fiance then shot and killed a police officer and pharmacist as well. I highlight her because I think it's important for us to kind of, for those of us who live in the United States, to acknowledge that statistically, almost all of us are going to have a personal family either family or personal story in addition to the clinical stories, and that those make up for so many of us part of our motivation, but also part of the drive for change. And I think that the more that we share our stories, as we saw with This Is Our Lane and as we're doing within AFIRM, the more that we can normalize the conversation about this and turn this into a movement that is effective. You look at civil rights or gay marriage, right? What was the difference there? It was people talking about it incessantly and making it something that was not embarrassing or stigmatized, right? And spreading a message that this is something that we can and must take on. And one of the things that I've been most touched by in working with the folks here at this table, as well as some of you in the room who I've known already, is the degree to which we are beginning to create that movement for change and beginning to overcome these kind of traditional political boundaries. So I welcome you to check out Affirm, but I'm also super excited to work to hear Pat's and Lauren's and Emmy's and Jeremy's presentations on some of the solutions that are already being developed across the country. Thank you.